So I wanted to introduce myself. My name is Deborah. I think I've met many of you while I was in Barbados, but welcome to anybody that is new. This morning, we're actually going to talk with Laura O'Brien, who is our standardized patient coordinator. And she has been our coordinator now for a year and has been doing just an absolutely phenomenal job. And I think has a lot of great insight to share. So Laura, would you like to introduce yourself?
Sure. Hi, everyone. My name is Laura, and I have a lot of experience with SP programs. I was even an SP at one point. My background is I am a nurse as well. So I have the nursing background, the SP background, and I have experience running the program and hiring and all that fun stuff that we're going to talk about today. So I'm eager to engage with you and hope everyone has a good learning experience today.
Awesome. And just to give you a little bit of background, I prior to Laura coming on, then I ran the standardized patient program, and we only had it for a couple of years until we realized the benefit, and then Laura's position was approved. So I'll kind of talk through what that initial first couple of years looked like, and then we're gonna let Laura talk in more detail. So, all right, go ahead and next slide, Laura.
Okay. Oops. Sorry. Yeah.
There we go. So this just gives you an idea, an agenda of kind of what we're going to do between now and about 11 o'clock. We have about 90 minutes total. I'd love to hear more about who is on the call and kind of what your areas of focus are. We're going to actually talk about why we do simulation. What's the point of doing simulation in healthcare? What are the standardized patients and how are they used in throughout the university and to train the School of Nursing students? We're going to go over two scenarios that we tend to do in the fall, I believe actually in the fall and the winter, each year with our students, and then talk more about administrative components of how do you recruit and train your standardized patients, how do you teach them to give feedback to the students, and then how do we get feedback on how our simulations are running. And then we'll just end with some questions and try to answer any questions that we can. Okay, so I started a class actually, it would have been in 2019, called Healthcare Theater here at the university. And essentially what we did was we brought in the School of Nursing faculty and then also the theater faculty that we have on campus to train actors to basically be patients for us, and the art of communication, how to do standardized encounters. And then really we wanted to talk about how do we empower the participants to use this as a setting where they can become more comfortable working with families and patients. So we ultimately did a lot of work with the theater faculty to show the students how to physically portray a headache or how to physically portray nausea and vomiting or back pain. And we had a lot of fun with it. The students absolutely loved it. I think we had 10 students in the first cohort, and you'll see a picture of our first group in a little bit here. But because of that class taking off, then we were able to kind of network into the theater department and recruit a lot of students that wanted, it was a way that they could make money while they were in school and they could practice kind of the skill of what they were learning. So it really did take off. And we wanted to teach them how to present barriers to the students, the nursing students that were trying to get started into the clinical setting. And then we wanted to also teach the nursing students how to react to the certain behaviors that, patients and families will exhibit and how to respond to those. So doing a lot of improv work. And provide the standardized patients then were able to provide some constructive feedback to the students about, I liked it when you did this to reassure me, and I didn't like it, and so it was really around creating a good bedside manner for the nursing students. So, and then we actually had a second cohort or group of students that we were training, and it was during when COVID hit. And so we had been in class for 6 weeks, and then COVID hit, and we had to basically cancel the class, or we went to online. But it since then, we've not gotten the healthcare theater restarted. But we have Laura now, so she's been able to create a robust SP program for us. So really, we want to talk about why is it important to get the actors, and that would be next slide, Laura. And it essentially is to get the students comfortable to go into the clinical setting and be prepared to deal with all of the different populations that they're going to face. So whether it is, somebody that is maybe a veteran, or somebody that has PTSD, somebody that's having anxiety, how do we train those students to work with those patients? And so it's really to practice their communication skills. And sometimes they don't realize things that they are doing. So the SPs and the actors can point out different things. As an example, I had a student last semester that thought he was saying everything correct, but he was getting ready to examine a female student, and he said, "Let's just take a look under the hood." And I was kind of like, okay, we need to correct that. We need to work on that. And so I brought him out of the room, and I helped him understand what he had said. And so he now is able to make it a little bit more smooth. And then we practice physical exam skills under close supervision. So we want to make sure they're doing an appropriate physical exam, and let the students make mistakes and give them an environment where they can try different techniques and different approaches, and we can all help the student work through that. And ultimately, it does build a lot of confidence for the students, because we can put them in several different scenarios, and so they're not so scared. Even if they're starting into their psych rotation, sometimes that's scary for those students, so they need practice. And then we want to prepare them for the hospital as best we can. And then if you remember where we have our SP events, so a lot of you saw a tour of our facility, but this is an example. We basically use standardized patient rooms that are set up just like a clinical exam room would be set up, or we could make it a hospital situation. So we can pull the mannequins out of our rooms, put in just a stretcher, and then the actors will actually go into the simulated areas. And you just want to put the students in whatever, as much fidelity or as much, realism as you can in the process. And so we've done things as far as we'll dress the students up or our actors up as if they were a prisoner. And so we would put them in a prisoner outfit, and so that the students can get comfortable, working with that population and talking to them and asking appropriate questions. So however you can create the most realism you can is what you want to do. All right, and I think I'm going to let Laura take over from here.
Okay, thank you, Deb. So I'm going to get into what actually is an SP. So you've probably heard the term. Sometimes it's called simulated patient. Sometimes it's standardized patient. Here we use standardized patient, or short form SP. And that's a person that you train to portray a patient case, to document how the student performs, provide feedback on interpersonal skills, and from the patient's perspective, give feedback. How did you feel as a patient? So it's invaluable information to the students. There's also something called a Standardized Patient Teaching Associate, SPTA, and they are SPs who receive additional training, and they can, and usually a certificate from a program, and they can basically do more than the average SP in terms of grading, physical exam techniques, for instance, or certain skills, and that sort of thing. But here we're talking about just the standard or the average standardized patient. So I want to get into who are our SPs. So from the community, we have a nice picture here, and you can see Deb is all dressed in red. This was taken a few years ago before I started, but this was their team of SPs from the community, a lot of students, and I'll just get into that.
That's actually our first group of healthcare theater students that we got through. So
okay. Yeah, so that was the inaugural SP program here, our first set of SPs. So I just want to talk about our standardized patient community. So who do we have? Basically, most of our SPs are paid employees. We have one that's a volunteer. She's a retired nurse who loves to volunteer for us when she can. But the rest of our SPs are paid. And they consist of, the majority are college students and not in theater. We have a few in theater, but most are just in humanities or science, biology, just different disciplines. They do it as a part-time job, and they do quite well. And we do have some theater students that are great as well. And we have a few retired individuals, so middle-aged and over 65. And I'm trying to get a few more so that we have more of a mix, especially during exam time when our students are busy. It's good to have some people that don't have exams, and so that can help us run our exams. So that's basically the people in our program.
And I would say that the faculty would love to see us get more and more and more diversity amongst our different SPs, so that they could literally make up a case and we would have, kind of somebody that would match that case. So we're trying very hard to recruit more. And the challenge, one of the biggest challenges, is in pediatrics, right? Trying to get children that, and so far, we have had, 18-year-olds portray like a 14 or 13-year-old, but we really have not had younger that I'm aware of. Laura, is that true?
That's true. We don't have any pediatric SPs. So, yeah. And I think there's some legalities involved as well for anybody under 18 or under 16. So, yeah.
No one just...
And yeah, the few times we've had to have a pediatric, oh, my light just went out. Sorry. The time we would use, the SP would play the parent or caregiver, and we would have a mannequin in the bed as the 18-month-old or 2-year-old, something like that. But yeah, it'd be good to increase the diversity and ages in our pool. So that's one thing I'm trying to work on. Yeah. Okay, moving along. So I want to discuss how do we use SPs? So here at the U of M, what we do is there are two main ways that SPs are used for simulations. So it's either live or in person. They come here and we get them into the rooms to meet with the students. As well, we do telehealth. So using Zoom, just like we are here. We have a breakout room. So we have a faculty in the breakout room with their camera off. We have the SP in the breakout room. And then I just send the students into the breakout room to do their telehealth. So that it works really nice. And telehealth is really up and coming. So it's a great learning tool for the students. I wanted to get in what are the 3 types of simulation events that we do. So as I said, we do telehealth simulations. We also do in-person mental health simulations, and those are for our undergraduate nursing students. And we also do in-person medical simulations. and those are for our nurse practitioner students. And we use the SP rooms, which I'll get into soon, but they're basically exam rooms with an exam table. We have cameras there, so faculty can watch outside. We can record the interactions, so that's always helpful. So those are basically the three types of events that we run. You're probably wondering what kind of clinical situations do we do? So I know there's a lot of mental health nurses here, as a lot of you said that, and actually my background is mental health, so I'm with you on that. So we do several mental health situations. One we do is a young person with psychosis. Another is a freshman in college who is assessed by the nursing student for alcohol consumption. We also do a case on a middle-aged person with depression. Our medical situations are quite varied. We have a pneumonia case, a COVID case, knee pain, back pain, birth control options, and a cancer case. We also have a case using an 18-month-old. That's the one I was talking about, where we use a mannequin and the SP plays the role of the parent, and they provide all the developmental information to the student. As well, we have what's called a difficult conversation case, and that's where the SP plays the parent or the caregiver, and they are receiving bad news about their child. So that's an interesting case that we do.
And I would say in this, where when we were doing the 18-month-old and then the SP was the parent, the faculty actually did record a child doing a milestone, and then the SP would actually have the nursing student in the room watch what the child was doing so that they could assess it. And I thought that was a pretty interesting way to add more detail to the case and let the students do the critical thinking.
Yeah, thanks for that, Deb. I had forgotten about that. That's right, and I think it was really valuable since we didn't have an SP, an 18-month-old SP. So that was good. So that's a trick of using a recording. So I think that was really good. Went really well. So moving on. So you're probably thinking, well, what is our process from start to finish? So how does it work? So basically, we have the planning phase, then the coordinating phase, the preparation phase, and then the implementation phase. So first off, planning, need for simulation. So it all starts with faculty. They decide that they've done a simulation before, or they want to do a new simulation, and they let us here at the Clinical Learning Center know that they want to do a simulation case using standardized patients. So we have what's called a reservation form that they fill out, basically the course, the date they're planning, the timing, how many students they have in their course, how many SPs they're going to require, and any props that they might need for this simulation. So then that gets sent to me, and then I like to use Google Forms. And what I then do is I communicate with my SPs and through Google Form. And basically I send out the dates, and the SPs can sign up on the Google form, and it's all in one spot, and they can sign up, and then I can go ahead and start scheduling for that simulation. Then once I know who's going to be doing and doing the simulation, I send out a schedule. And so they all know as well. Then I send out another Google form asking when the best time for training is, because we always do a training for each case. I want to make sure that the SPs are very well prepared for these simulations. So then we come to agreed upon time to do the SP training, And I don't know what they used to do in the past, but since I've started, we do Zoom training. So it makes it easy for everyone. They can do it from home. And because I have a lot of SPs who are students, they prefer to do the training on the weekend. So I usually tend to do training on Sunday evening between 7 and 8 p.m. That works out well for everyone. So what happens is I'll get the case from the faculty, and about a week before the simulation, I'll send the case out to the SPs. And then we'll arrange a training so it's within that week. If it's any further outside of that, I find sometimes then it's not as fresh in their mind. So I like to do it as close to the simulation as possible, do the training as close to the simulation as possible. And so we meet for about an hour, and I go through PowerPoint slides. And so they receive the case, so they've had it ahead of time. And that way they can prepare any questions that they may have, and that sort of thing. So we go through a training and on Zoom, and then they're all set for the simulation. So then the implementation is basically the day of the event, the day of the simulation. So if the simulation, a lot of them start at 8 a.m. So I have the SPs arrive around 7:30 just to come, and we do a pre-brief. Basically, if something's changed, if anyone has any questions, if anything comes up, everybody's on board. Everyone receives all their information of their schedule, what students they're seeing, what rooms they're in. They get settled into their SP rooms. And so then we can start the simulation right at 8 o'clock. And I think that's about it. So that's basically from planning, coordinating, preparation, and implementation. So moving along, I actually have two scenarios that I wanted to go through, and so you can see our process. The first one is a Margaret or Mark Williams, depending if it's male or female, case. And for all you psych people, it's depression and suicide. So we're going to go through that case. And then the second case we're going to go through is the nose, and that's an allergy case. It's a patient coming in sure that they have a sinus infection when in fact it's allergies. So we're going to go through those cases. Were the cases sent out, Deb, to Renwick? Does everyone have them?
Gabby Clark. So I don't know.
Oh, okay.
But should I send them to Renwick? Can I send them to you right quick too?
Yes,
so
you can.
At least have them. Okay.
Okay.
Right now.
That's great.
I want to make them available to all the others also too. No.
Yeah. Anytime, just so that the faculty will have them moving forward. So if
Okay,
they
great.
do a case, then they have one to look at.
Oh, no problem.
And that's actually one of the cases I was going to talk about on my session in terms of from a faculty perspective, why we chose that, and maybe show live demo, or I may show the adolescent case that Deb was talking about. So, and I will send the adolescent case in advance for mine.
So should I wait a few minutes for everyone to get it, or should I just start? Because I'm sharing, I have it up on my screen.
I think you could just keep going.
Okay.
People will just have it if they want it afterwards and not be frantically noting down things they want to remember about it.
Right.
Okay. Okay. So this is Mark Williams' case, depression and suicide. And this is a case that we do for undergraduate students during their psych rotation in their third year. Basically, it's to develop their communication skills. So I just wanted to go through some of the goals for this one that we've set. The communication, the student will engage and work towards improving their communication skills, interacting with the SP and the healthcare team, and learning experiences around communication interactions. Safety. We get into that it's making the students aware of the safety concerns in dealing with the patient and the environment, recognizing changes in their conditions, and being just aware of the whole situation. also medication safety and following policy and procedures. And this case is good for skill building and clinical reasoning. They can explore new interventions, new assessment techniques, try something new you've never done before, go outside your comfort zone and take risk, because that's all part of this standardized patient program. Is they can try it. No one's going to die. No one's going to get hurt. Nothing bad is going to happen. It's purely for learning and to try something and see if it works. And if it doesn't, that's okay. Recommend a strategy or treatment, all of that those good things, and address the problem or issue. And then after the students meet with the SP for this one, then they have a debrief with their faculty and they discuss their performance. For this one, some faculty actually have them videotape just with their phone, set up a tripod and record themselves. And then basically during the debrief, they reflect on how they did and watch themselves. So that's also a good learning tool. So they can discuss with other students as well as look at their own performance. It encourages professional behavior, and they're expected to arrive on time for the simulation, dress appropriately, and bring their equipment, whatever equipment they need, and be respectful. So I just want to show you the report that is shared with the students just before they go in to the room for the Mark Williams case. They're not given very much information. Here's the scenario that's printed out. It's Mark Williams is a 59-year-old unmarried legal assistant who is admitted to the psychiatric unit following a gastric lavage in the emergency department. She had ingested 30 imipramine tablets. She's employed in a large metropolitan law firm. You are the nurse assigned to perform her admission assessment. So that's the main goal. They're supposed to go in there and do an admission assessment. So that's all they're given. So now these are the details, the printout that I would give the SP ahead of time before we have the training. So Mark Williams, therapeutic communication, details to be used by a sim actor. So they're given the name of who they're going to play, the age, they're unmarried, a legal assistant, same sort of information that the student is getting, that you took a lot of pills, you ended up in the ER, you had to have your stomach pumped, and you work in a law firm, and now you're on the psychiatric unit upstairs. Your presentation is you're overweight, disheveled, wearing mismatched dirty clothing. You slump in your seat, you avoid eye contact. So basically, I would give them guidance on how to dress for this. So I have a whole wardrobe here. So some of them prefer to dress, sorry, my light keeps going out. It's an automatic light that turns off. So I would basically choose some clothing, or the SP may bring their own clothing from home, but really to look like a depressed patient who's not caring for themselves and avoiding eye contact and is just not very engaged. So they're cooperative, slow to respond to questions, oriented to time, place, and person, and judgment is good. Deb, did you want to add something?
Oh, I was going to say having these descriptives is very important for the standardized patients. Once you give them or paint a picture for them, so to speak, then the students are very good. The actors are very good at creating what it is that you want. So it is fun to create the cases sometimes.
That's right. Yeah, no, I agree with you. And then the students, or not students, well, they are student, but the SPs, they do a great job of portraying the patients. And some of them are really good at even crying with this one, if you're able to cry. And I have a few that are just they can cry on cue, and it's quite and appear quite distressed. So it's good. And I have a mixture of new and old SPs. So what I'd like to do during the training is I get some of the more experienced SPs to offer suggestions to the new SPs on how they've portrayed the character before. So that's always good to use that experience that we have in the group.
The other interesting, I hadn't worked on this before, but we had an SP that was actually over portraying some cases, and it was distressing to the students. So just watch as the actors are doing their cases and make sure that you're not distressing the student either. So
that's a good point, Deb. Yes, sometimes you will get somebody that sort of goes over the top. So that's why it's always good we have cameras, so I'm able to watch them during the simulation, so I can kind of just keep tabs of what's going on. So that's always a good to sort of know what's going on and get the feedback from the students if they feel like it's been a little bit too intense. So yeah. Okay, so moving along, so some more descriptives. Their abstract is slow, but unimpaired. Affect is depressed, weeps. So you'd want weeping more than like howling, and no delusions, illusions, or hallucinations or other thought disorders. So then we get into more just a description of the client's problems, what's been going on. She's distressed. She's worried that people will find out she's in the hospital, know her business. So she's quite worried about that, he or she. She's been at home alone for 2 days because she became convinced that no one would care if she died. So that sort of was the impetus to taking the overdose that her family doctor had prescribed. So she had become frightened. Let's move this up. She became frightened after taking the overdose and couldn't make herself vomit. So she called 911, and that's how she ended up in the emergency. She is quite concerned about her impending retirement at 65. So she does have some issues around that. She's alone. She's built her life around her work. It's her everything. And she does have an elderly mother that she's sort of required to step in and look after. So that's a stressor for her. She doesn't have much of a social life, except for coworkers. She has no friends. She stopped going to church. She felt she didn't fit in. So she's really starting to isolate herself and doesn't have a lot of support. So we've given the SP more details. Her mother's 84. And again, the SP isn't required to give each and every detail. It's just so that they're aware of most of these details, depending on what the student asks. So the mother is 84, lives 3 hours away, and is experiencing a deterioration in her health. And she's expected to be the caretaker. There are other siblings, but she is going to have to look after her mom or have her come and live with her. So some of the details that the SP will need is for the past 3 weeks, she's not been sleeping, losing weight, crying, irritable, and having difficulty concentrating. She's had suicidal thoughts, but no specific plan. And they asked her at her law firm to get herself together and told her to take some time off. So that was distressing because work is her everything. So she was at home alone and just feeling really bad and feeling unattractive and that sort of thing. So then we get into a psychiatric history that she's had no previous psychiatric history, though she has had the blues. She is supported by her family doctor and prescribed the medication. And again, family history, she's the oldest of 5 children and grew up in a small town. Some information about her father, he had bipolar disorder. Her mother had some difficulties as well. And there isn't a lot of contact with the other siblings. So I'm not going to go into all this detail, but this is the kind of detail that we give the SPs.
Yeah. And we do have a character development worksheet that might be helpful. I could send along too, that really asks these sorts of questions, like what is the social history? What is the background and significance for each of the characters, so that you can build this as a profile and use it for standardized patient events. So we'll definitely share that, because the more detail you can provide, the better the actors can portray exactly what you want. So,
right. That's a good point. And giving quotes whenever there's something really important that you want to, that the faculty maybe want to really stress. And then I always highlight it as, a few statements that you really have to get in there somehow. So anyway, this is a bit more detail, and you're going to get these cases. So you'll be able to, go over it. And we also give the vital signs to the students, usually the height and weight and the health history and any medications they're on. So that's the end of that one. Were there any questions about this one before we move to the second one?
and I would maybe, just for time's sake, Laura,
Yes. Okay.
go briefly through the next one, but maybe not
Okay.
get into
Okay.
much detail.
Okay. Got it. Okay. So let me stop sharing that one. I'm going to pull up this one. Okay, can everyone see it? Okay, so this one is the nose, and this one is in a different form. This is a new template that one of the faculty and I created together, and we're trying to use this one because it gives all the information, all the different categories. So the case scenario, we have just a brief, what you're coming in for, sinus infection, you're having congestion for the past 2 weeks, nothing's helping, and you want an antibiotic, and you really want them to prescribe an antibiotic because you get this every year and you just need an antibiotic. So I won't go through all of this, but as you can see, all the different categories, so that on the right-hand side, the faculty is able to put in all the information so we don't miss anything. So it's quite long in length. It's about 11 pages, but we're able to put in all the diagnoses and the standardized patient instructions. So here it is with their name and their history, and all of that is there. Here, more information about what their occupation is. And here I was referring to what they need to say. So opening statements that we would really like them to say. And then history, all the details, ratings of the pain, and other details that the SP knows, and review of systems. And then we get into even the lifestyle, sexual history, family medical history, and any key points that we want, that you're going to start off friendly, get a little cranky if they don't give you the antibiotic, and push. You're a pushy patient and you know that you have a sinus infection and you want an antibiotic.
And as you can tell by the level of detail that the standardized patients really have to spend some time preparing to come in and do these cases. But once they do a case, they tend to remember it very well. So it's not as much prep time as you do more and more of the same case. So
that's right. Yeah. And then at the end, I just wanted to show what we give to the students. So this is this sheet that or the case that is right outside the door of the room. So when they're having their simulation, they come over, and this is the printed sheet. It basically just says what the chief complaint is, what they're expected to do. And you may enter the exam room whenever you want. And then we also put it in a clause about not sharing the case with anybody, that it's confidential. Then the second part of that is just the patient information. They're given some of the vitals, height and weight, and then they are to go through and fill this all out. And then at the end of the interaction, the standardized patient gives them what's called a physical exam finding sheet. So that's anything that we want the student to know that they weren't able to get from examining the SP. So nasal congestion, that sort of thing. So this is given to the student. So you all should get a copy of this one. So hopefully that helps you with your case development. I'm just going to go back to my PowerPoint slides.
It is interesting. The students are so used to doing these cases. They'll get to the end of visiting with their actor and they'll say, "And do you have a physical exam finding sheet for me?"
That's right. Yeah, they know, you know. Yeah. There we go. Okay. Okay, so moving along. So for SP recruitment and training, I wanted to talk a bit about that. So who and how? Who do you hire? Who do you recruit? And how do you go about training them? So volunteers versus paid employees. So, you know, when SP programs are first starting out, there aren't a lot of funds. It's very difficult to fund this and be able to pay people. And so you have to be kind of creative in how you're going to get volunteers. So some of the ideas would be having a course that people take, like students take part in, and then they can be an SP for your program, as well as students at your college. Maybe they can get volunteer hours or just some experience for their resume, so they would be willing to volunteer to be the role of a standardized patient. The other thing you might want to consider is retired healthcare workers, people that have retired and want to give back to the community, would be interested in helping you out in playing that role. So that's an area that you can investigate for your program. Retired nurses, possibly alumni from your college that would be willing to give back and volunteer. And then last but not least, friends and family. Beginning SP programs use friends and family to start off with, to train as SPs and work when you know, you're just starting out, and can be a really effective way to get people to help out and start your program.
I will tell you, the retired healthcare workers tend to be phenomenal because they're committed to the cause and they really want to help the students. They love working with the students, and for the most part are very helpful to train for bedside manner. So that's always good. And then I think all of our families have at some point or another come in to be standardized patients for us.
Yeah, you got to do what you got to do to make the program work. Yeah. Okay, so moving along. So what really is the role of an SP? Well, it's to portray a role, certain conditions, pain, nausea, cough, headache, whatever it is, and provide specific details to learners based on the case. They're going to assess the communication skills of the student, and, you know, using some checklist of what communication skills to look for, assess these skills, and then provide feedback to the students. Here we're mostly doing verbal, but we are planning to get into some written feedback as well. And that's always good, something that can go to the faculty, something that can go to the student themselves so that they have a reminder. Maybe they'll look at it before they do their next simulation and remember what they needed to work on and improve so that they're always improving. So next I want to get into how I train the SPs for the role. So after I hire somebody, we usually provide an inpatient orientation to all new SPs. So that's 2 to 3 hours in length. They'll come in person, and we'll go through a whole orientation. I usually bring in some experienced SPs to go over some cases with the new SPs. And we just go through all the administrative stuff, how you sign up, when to come, what to do, how to learn the cases, training, all that sort of thing is covered. As well, we happen to have a link to an online training module that we've been encouraging the SPs to complete. That gives them a fuller training experience. Then next, I would have them observe another SP during a simulation, during a couple simulations for at least 2 different cases. And what I like to do is do a mental health case and then a medical case because they're both so different. So they'll observe the SP, and then at some point when they feel comfortable, they'll actually try out the role. So they'll go in and see the student for one simulation, and then they'll meet with an experienced SP and get some feedback. And then maybe go in again and then get some more feedback. So they're constantly learning and getting experience before we just let them go and become an SP. So a lot of training and feedback is involved. And so as you know, you're called a standardized patient. What does that mean? Well, we really want the SPs to remain standardized. So consistency, saying the same things, not giving one student an advantage over another, saying the same thing. And each interaction is not going to go exactly the same because students ask different questions, but it's responding the same, not giving out too much information, saying the same opening statements and other statements that we may want given. You need to be consistent during multiple times. Sometimes SPs will see 7 to 10 students in a day. And so they really need to be the same. And it all depends on the students, how different questions will lead to different answers, but it should still try to remain consistent. And I stress with new SPs, they tend to be a little bit, I guess they're anxious and they want to give out more information. And what I stress is make the student work. Don't give all the information right away. They say, so I gave an example. So if you say, oh, I have a really bad cough, and the student says something like, tell me about your cough. If they said, just tell me about your cough, then you could go into a bit of detail. But if they say, tell me about your cough, how long have you had the cough? So they've asked you, how long have you had the cough? So just answer, the cough started about a week ago. Make them ask more details. They have to ask the questions in order to get the information. So how to prepare. So what do I tell the standardized patients how to prepare for meeting with the students? So I train them online. They may have some assignments. They may want to do some research on the internet of, how do I cough when I have pneumonia, or how is maybe there's a video on a depressed patient, so they could watch something like that. So watching online videos is good, and practicing on family members, going through, feeling comfortable. I expect them to come prepared for the training session so that they can ask any questions. We can go through any medical definitions or anything that they're not comfortable with or unsure of. And we want them to become comfortable in portraying this patient. And I also want them to be able to provide feedback to the student. So they need to know what exactly they need to be commenting on. So that leads to SP feedback. So I love this quote from Bill Gates. We only need people who give us feedback. That's how we improve. Otherwise, we're going to stay the same. So that really is the goal. We want the SPs to give valuable feedback to the students and the students to take that feedback and improve with each subsequent simulation. Oops. So first, verbal feedback. So this is what I tell SPs when they sort of what they should say about giving verbal feedback. Once the simulation is over, they break out of the character, introduce themselves. Hi, I'm Laura. And this is the feedback portion of the interaction. We have about 10 minutes, and I'd like to offer you some feedback based on your communication skills. Would that be okay? So asking permission of the student. And first, and it's always good to ask the student how they felt it went. A lot of times the students know very well what they did well and what they didn't do so well. And it's good if they're able to do that reflection. And also then you're able to build on what they say when you give the feedback. And a lot of times they're harsher on themselves. So a lot of times they will identify their weaknesses. So I just want to go through how to give the feedback. They'll ask, how do you think it went? And the student will talk about what they did well or what they didn't. And then you describe a specific behavior of something that maybe, they thought they could improve on, or you thought they could improve on. So is there another way you could have ended the interaction? Maybe the interaction ended very abruptly and it wasn't clear to you as the patient that it ended. You didn't really know what was going on. What were the next steps? So you could say, well, is there another way you could have ended the interaction? And so get the student to reflect on that. And I use what's called the sandwich technique, one positive, one constructive comment, and then ending with a positive. Students can only take in so much, so you don't want to give too many constructive comments, or they might not remember them all, or just remember only one. So it's good to select the highest priority, something that really stuck out to you. And a good way to phrase it is, as Mary Smith, I really felt that, you were really just trying to answer all the questions and rush through the interaction, or whatever it happens to be. But if you portray it and verbalize it that way, sometimes it's the constructive comment is taken in a better way than I thought as the SP, or as the person, but as the patient. And then just to verify the feedback. So so next time you're going to work on, trying to end the interaction with next steps, and ask me if I have any questions at the end, something like that. So you reinforce what they're to work on. So it's very clear to the student. Some other areas that I have the SPs focus on is really, how did you feel as a patient? Did they set an agenda? Did they tell you what was going to happen? How was the rapport? Did they allow you time to speak, or did they do all the talking? It really should be 50-50 at least. Did you feel like you were validated? Empathy, were they interested in you, or they just wanted to go through a checklist? And really, what is the difference between empathy and sympathy? Well, empathy is really getting at that emotion and feeling compassion and understanding what the person is going through, the patient's going through, as opposed to sympathy, which is more pity or feeling like, oh, I'm glad I'm not in her situation. So we really want the students to acknowledge the patient's feelings and display that empathy. And that's always a good area that the SP can comment on. So a few more areas: the organization and flow. Were they asking quality questions, professionalism and confidence? Were they dressed well, or did it look like they just got out of bed? Did they provide a good summary and conclusion to the interaction? So those are all areas that the SP can focus on. Open and close-ended questions. So we really want students to be asking open-ended questions, because you get a lot more information than the close-ended questions, which result in yes or no answers. So as I said before, providing positive feedback, positive, and an area for improvement. And then just to be objective, you want it unbiased, you want to comment on something, and that's not influenced by your own prejudice. So the feedback really needs to be objective. And what is the behavior? What behavior did you observe? Were they looking down at their sheet a lot, not making eye contact with you? You know, what was going on? So to comment on that. And then I just wanted to comment, being U of M, we like to collect data, and just collecting feedback data on the simulation experience from the SPs. How did they find the training for it went? Did it prepare them for the simulation? How was the simulation? How did it go? I like to do a debrief after, and then anything that was brought up, I'll bring back to faculty to improve, because we want to be constantly improving the process and the experience. And from the students themselves, how were they comfortable with the simulations? Did they feel, as Deb said, that one of the SPs was over the top and made them scared, and it wasn't a good situation? So we want to be aware of that and collect that information and do something about it. So now I'm going to pass it on to Deb to do summary and conclusion.
Awesome. So as you can kind of tell from what Laura discussed, is really using actors or using the standardized patients. It really is an effective teaching tool for the nursing students to experience. And I think it is a valuable part of their training and valuable for the students to get to practice. So we do definitely want to provide a psychologically safe environment for them to learn and make mistakes on. It is also important for the students to understand if they're in a formative simulation or in a summative simulation. So formative means it's mid-semester, they're working on their skills, and they are going to go in and practice with patients. Versus a summative situation is a high stakes, essentially, exam of, are you passing this portion of your education and able to go on to the next semester? So when we're doing summative exams, we really want the actors to stay standardized and be the exact same across the continuum, so that the students couldn't complain that, you know, it was an unfair situation, somebody else got an easier case, or were presented the case differently. So we're very careful to make sure that stays standardized at final exam time. And then I always think it's important to have them practice their physical assessment skills, because we learn it in our first semester, and sometimes we don't always continue to guide them in their physical exam skills. So watching how they do a neuro exam, or watching how they listen to heart sounds, lung sounds, those sorts of things is very important as faculty. And it's an opportunity for them to continue to improve their communication skills and get more comfortable talking to patients. So that's the beauty of using the standardized patients. And then last, really to talk about, recruitment, it's amazing what you can come up with, even if there's other faculty, or I have used staff before that are in the building, and I, last minute ask one of the secretaries, can you step in? And it's not always optimal, but I can, we can typically make it work. So I'll review the case with them, tell them what the really important components are, and a lot of times they'll jump in and they have a great time. So the one thing I would caution you on is putting somebody that is in charge of the students. So think about the hierarchy. So I wouldn't ever put the dean in as a standardized patient, because that's just going to ramp up the students and create tons of anxiety. Or put in the program director as a standardized patient. You really want it to be somebody that's anonymous or is in a friendly role with the students, so that they can actually spend the time learning. And then take the time to train your SPs which it took us a while to learn. You get a much better product if you do spend the time with the SPs ahead of, getting them prepared. And the students are starting to really, really like the feedback. They love the verbal feedback, because what happens is the faculty watch on video from afar and don't always get a chance to do some debriefing with the students like we should. We try to, but a lot of times we're trying to get through so many encounters that we don't. So getting instant feedback from the standardized patient is really beneficial for the students. And then we'd like to open it up for questions or areas that you might have on how can I implement this within different areas of whatever it is that you're teaching. And we can hopefully give you some ideas. And also we're happy to share if there's additional cases that you're wanting to do within your curriculum. A lot of times we're starting to get a whole library. So, I always say work smarter, not harder. Don't reinvent the wheel. And then also if you get onto mededportal.org, I put that in the chat, but that has a ton of pre-developed scenarios that you can pull up and use with your students. So some of them you would have to adjust a little bit to make it more realistic, depending on what your situation is. But we're happy to answer any questions if you have them.
Yeah, I got people started in the chat, so I think you have a question from Shirley in the chat. Oops, and somebody just fell off the Zoom, so I will let them back on. Oh, it was Janet, actually.
Okay.
So that's okay. I think she can get on herself.
What level of prompting do you give to the student during the simulation exercise? Meaning, can the standardized patient try to guide them if they're not quite getting the scenario? This is challenging because we don't want them to guide too much, and yet if it's formative and we're trying to help them, we definitely can give some hints. I don't know, Laura, what's your thought on this?
I think that sometimes that there's certain things that they have to get through to the student that's required that the faculty is asked that they say. So in that case, then they will need to get it in. If they can't get it until the end, they'll try, like you were alluding to the video. Sometimes there's not an appropriate time to show them the video, but they need to show that video. So if they haven't asked something that kind of alerts the SP to say, oh, would you like to see a video of my son? Then at the end, you show it. So there are certain things, if they're very important, then the SP will need to sort of then prompt it by disclosing it. But for the most part, if they haven't asked it, then they don't get that information.
Mm-hmm.
So I hope that answers your question.
Yes, it does. But is there any involvement from faculty during the exercise?
Correct. So you can have the faculty or have the standardized patient wear a earphone so that the faculty can give input during the case. We have not gotten to that level yet, but I do know that there's a fair number of facilities that actually are in constant communication of, can you cough more, or can you make sure that you're exhibiting a certain physical sign so that the students pick it up. So you can be in communication. I do know that our faculty and the standardized patients a lot of times will text back and forth, either after a case is ended or during a case. They'll try to give them hints. So
right. And I've actually had faculty run back from the viewing room to the SP room to talk to an SP about something, to how to change something, or so that does happen if they feel like it's not going, something's not being put across or something. So that's a possibility that you can do in between or at the break time.
And in the next session, I'll be highlighting from a faculty and perspective, how we develop some of the graduate level scenarios and how we do the telehealth ones. And on those, what faculty will often do is chat privately with the SP during the encounter. So the student can see it, but I could say to the SP, even though they didn't ask, please drop a hint about X, or remember, if they don't ask, don't say anything. I don't do it much. I limit it to when it's really necessary because it's distracting for the SP, but you can do that on a Zoom.
We did learn too, having the faculty closely located to wherever the SP event is happening is helpful, because currently where our setup is at, they're quite a ways apart. And so it's not easy for the faculty to get up from where they're at, run across the sim center, pop their head in the door and give feedback. So if you're able and you're designing how you want this to look, it's nice to have them close together.
And
Thank
actually,
you.
a low tech option I've seen is you can just use a curtain or a screen if you want the faculty to. If you don't have that camera option, you can actually set up an SP in a classroom, put a faculty behind a screen or a curtain to listen. You know, if you're thinking about how do you do it when you don't have cameras, how do you do it if you don't have a room set up yet? It's not that you can't use actors and get benefit for students. There's ways to make it work.
And having the students recorded on their phone, they can set up their phone as they come in the door and say, I just want to record this so I can review it later. And the students learn a lot from watching themselves with a patient. Did you have something, Renwick?
I'm trying to, hold on. Oh, can you hear me?
Yes.
Yeah.
So the viewing of the exercise, is it an exclusive viewing by the student themselves, or the other students are allowed to see?
You can do it either way, but typically we just let the individual student review it themselves.
Okay.
We don't want to make them uncomfortable or feel like they're being critiqued by their fellow
Yes.
classmates.
Though I do have one psych faculty that does the sim right in the room. So everyone likes to sort of do it different, but I have one that the student and the SP will be at the front of the room, and then the simulation will take place, and then everyone will give feedback, including the students and the faculty. And then the next student will come up, but they've heard the feedback, so then they sort of know what to improve on or ask. So that works as well.
Yeah, I like your approach. We have experimented with it before in psychiatry because, you know, like with general nursing, you're trying to extract a lot of subjective information from the CLED. And sometimes we do I've done impromptu role plays, but sometimes the students tend to exaggerate the symptoms and make it kind of difficult for the other students. So I do like the idea of planning some weeks ahead and really preparing for any type of scenario. I really like that approach. I endeavor to try it. So you have the videos placed and the faculty will watch the video and give the student. So the debriefing, the student encounters with just one member of faculty or?
Right. A lot of times we will have the student come in and give a oral report, a 5-minute oral report on what's going on with this patient that you saw. And so the faculty can then see how much they captured, what their plan would be moving forward. And then at that point, the faculty can give the student some feedback. So it's interesting, only about less than 50% of students will ask or feel comfortable asking about sexual health. And so it's interesting to watch the different SP events and see who's comfortable talking about sexual health. So
yeah, it happens here too with in psychiatry when you're getting down into preference and orientation. It's very difficult for the students to negotiate those type of conversations.
We did have FNP faculty, and Megan can probably talk to this more so, but we actually had 4 transgender standardized patients that we paid to come in and meet with the students so that the students would get comfortable asking questions with the transgender patients.
Yeah, I'm not faculty on the course that did it, but I'm part of the faculty group that developed that. And that was really invaluable because it is different to talk to someone where that person in front of you, that truly is their identity, right? And they were trained, the transgender individuals were people who were very passionate and very trained in trying to help healthcare providers communicate in a more respectful way. So that was a really good learning experience. I think one of the unexpected challenges on it is for students for whom being in the US is already an unfamiliar culture, it was particularly challenging. Students whose first language doesn't use gendered pronouns anyway, who mix up he and she in English anyway, it was extra confusing. So anytime you sort of push the envelope and try to get people to engage with topics that they really are struggling with communicating around, we as faculty even uncover things that we hadn't thought about. Because I think the faculty group had not thought about what that would be like for an international student coming from a language where it really was getting into linguistic confusion for them.
Yeah, we attempt the same thing here. I teach a course called Transcultural Nursing, and focus a lot on diversity. And we have had transgender individuals in to discuss it. We've had different religious groups, Rastafarian, Muslims. We've had those persons in. I think one of the, but I find that we have to prepare the students well in advance before they start to have that engagement. I remember when I first started the course, one of the mistakes I made, as eager as I was to bring these persons in, I started that a little too early before I actually prepared the students for, using the right language, the pronouns, and not letting their convictions govern their questions and their opinions and their attitudes towards the individuals. But I find that I had an atheist in once, a lady who was a lawyer, and that was interesting. And if you know Barbados, we're a very religious type society, and immediately after the session, that's what the one where the mistake was made. The students tend to circle her and wanted to pray for her.
Oh, wow. Interesting.
Yes.
Yeah.
Yeah. So, but it was a really interesting learning experience, because then I was able to pull them back in and had the conversation with them. I know about presuming that their way is the only way, and that you must respect persons despite your difference, and their differences. So I find that works very, very, very well, and they respond to it much better than me standing, making assumptions and reading from a book, to hear it straight from the person. It really has been an effective and powerful tool from my point of view.
Yeah. Yeah, and I think we as faculty always learn. And I think you're so right. That's what the group that set up the transgender encounters, I think, learned the first time through, was that they needed to prepare the students even more before that, for the students to be able to really learn and engage, rather than having it be, I think some of the students the first round almost felt like some of the faculty were trying to shock them on purpose or something, or trick them by shocking them. And it wasn't meant to be that. And so the faculty had to work on preparing the students enough that it didn't feel like they were being set up to, quote unquote, fail and then be confronted about it, but rather, setting it up in a way that was I think, more compassionate to how difficult it was going to be for some of the students.
I do want to be cognizant and careful of time because I know everyone has busy schedules. So I am happy, Laura's happy to, and so is Megan, to